Hello, I'm David Gershenson, professor of gynecologic oncology and reproductive medicine at the University of Texas MD Anderson Cancer Center. I'd like to thank the Ovarian Cancer Research Alliance for the opportunity to provide a brief overview of low-grade serous ovarian cancer. I'll be covering some basic principles as well as the current landscape of first-line therapy for patients newly diagnosed with low-grade serous ovarian cancer. These are my disclosures. So ovarian cancer, or epithelial ovarian cancer, is not just one entity. It's actually composed of multiple subtypes. There is serous, which is the predominant subtype and accounts for about 65 to 70% of all epithelial ovarian cancers. And this is subdivided into high-grade serous ovarian cancer, which is 90% of that 65%, and low-grade serous ovarian cancer, which is only 5 to 10%. So low-grade serous ovarian cancer represents one of the four rare types of epithelial ovarian cancer. The other three rare types are endometrioid, mucinous, and clear cell. So over the past 30 years, up until about 2010, we made actually very little progress in the study of low-grade serous ovarian cancer. And there are two major factors responsible for that. This slide shows you a 30-year landscape of phase 3 randomized clinical trials for women with advanced stage ovarian cancer. And the problem was that all of these subtypes were enrolled in the same trials. And so the rare subtypes were completely overshadowed by high-grade serous ovarian cancer because of its frequency. And so over that period of time, we learned very little about the rare subtypes. The second problem for low-grade serous ovarian cancer is that serous cancer was graded on a three-tier histologic grading system, but it's worse than that because there were two predominant systems throughout the world. One was the Chamizo-Silverberg grading system, the other was the FIGO grading system. Both of these grading systems had three tiers, and so there was no universal system. There were no criteria for defining the precise thresholds between the grades. And particularly for grade 2, we really didn't know how to handle that. The first decade of the 21st century and then really represented an inflection point for low-grade serous ovarian cancer. In 2003, the Human Genome Project was almost completed, and we began to learn a lot more about the molecular biology of low-grade serous ovarian cancer. Then in 2004, the MD Anderson group introduced a binary grading system for serous ovarian cancer that I'll explain in a moment, differentiating between low-grade serous ovarian cancer and high-grade serous ovarian cancer, so two grades rather than three. In 2005, the GOG, the Gynecologic Oncology Group, or what became NRG Oncology, established the Rare Tumor Committee. I had the privilege of being the first chair of that committee, and we began about the work of developing mainly phase 2 trials for some of these rare ovarian cancer subtypes. So this is the MD Anderson binary grading system for serous carcinoma. The major feature distinguishing low grade from high grade was the amount of nuclear atypia, and a secondary feature was the mitotic index, how many mitoses per 10 high power fields were observed. We also learned in this study that about 60% of low-grade serous ovarian cancers contain an associated serous borderline tumor. And we now believe, of course, that most, if not all, low-grade serous carcinomas arise from a prior serous borderline tumor. The next couple of slides show you some of the clinical characteristics associated with low-grade serous ovarian cancer. I mentioned it's rare, representing 5 to 10% of epithelial ovarian cancers. It's diagnosed at a younger age compared to high-grade serous ovarian cancer. Therefore, fertility preservation is a much greater concern compared to the overall ovarian cancer population because many of our patients are in their teens, 20s, or 30s. Approximately 90% of patients in almost all studies are Caucasian. We also know that low-grade serous ovarian cancer may arise de novo or following a diagnosis of a serous borderline tumor. It also may originate in the ovary or in the peritoneal lining. Approximately 60 to 80% of cases are stage 3, so we're not diagnosing low-grade serous ovarian cancer early. This is the same as with high-grade serous ovarian cancer. It's not a major part of the hereditary ovarian cancer syndrome because less than 5% of women with low-grade serous ovarian cancer have a BRCA mutation. Compared to high-grade serous ovarian cancer, low-grade serous ovarian cancer is relatively, not completely, relatively insensitive to chemotherapy. And it's characterized by prolonged overall survival. So in most of the studies, the average survival is somewhere between 135 and 150 months, compared to 40 to 60 months in the much more aggressive high-grade serous ovarian cancer. However, over 50% of patients will relapse at some point in their clinical course. In terms of the molecular biology of low-grade serous ovarian cancer, I would like to make two major points. The first is that this disease is similar to hormone receptor positive breast cancer. 95% of low-grade serous ovarian cancers express the estrogen receptor, and about 50% express the progesterone receptor. Like HR-positive breast cancer, women who are diagnosed at a young age, less than 35, have a significantly worse survival. And we also have learned over the past couple of decades that low-grade serous ovarian cancer responds to anti-estrogen endocrine therapy, just as HR-positive breast cancer, in multiple clinical settings: adjuvant, neoadjuvant, maintenance, and recurrent. The other important point to understand about the molecular biology of this disease is that the MAP kinase signaling pathway plays a major role in the pathogenesis of low-grade serous ovarian cancer. And in this schema on the right, you can see the RAS, RAF, MEK, ERK pathway is very commonly demonstrated in low-grade serous ovarian cancer. In 2022 and 2023, there were 3 studies that were reported, all of which showed exactly the same thing. So all of the studies found that about a little over 50% of patients in these cohorts, and these were all patients with low-grade serous ovarian cancer, had a mutation in the MAP kinase pathway, either generally KRAS, NRAS, or BRAF. And it was found in all 3 of the studies that those patients who had these mutations in the MAP kinase signaling pathway had a better outcome than those who did not. So there was a very consistent finding. This is from our study of 215 patients, showing you that the KRAS mutation was the most common. 71 of the 215 patients had a KRAS mutation, and slightly less common NRAS and BRAF mutations. And then there were a multitude of other mutations at a much lower frequency. In this study, as I mentioned, women with MAP kinase mutated tumors had a significantly better overall survival compared to those without these mutated tumors: 147.8 months average overall survival versus only 89.5 months. Additionally, we found an intersection with age at the time of diagnosis. So those patients who were younger at the time of diagnosis had a lower frequency of MAP kinase mutations and also had worse outcomes, as you can see there. So we've now accumulated over the past couple of decades data to pretty much tell us what the major prognostic factors are in low-grade serous ovarian cancer. On the left there, younger age at diagnosis or older age at diagnosis for better survival, lower FIGO stage, no gross residual disease at the completion of primary surgery. I've mentioned the presence of a MAP kinase pathway mutation and also higher expression of the progesterone receptor. On the right are some other factors that have emerged from a few studies, but I think we'll need further study to validate them as prognostic factors. Now to talk a little bit about the primary treatment of low-grade serous ovarian cancer. Primary surgery is the preferred initial treatment. So if typically an ultrasound will reveal a complex ovarian mass, the patient may present with an elevated serum CA-125 or a CT scan that reveals possible metastatic disease. Those patients should be referred to a gynecologic oncologist. Unfortunately, what occurs all too often is that these patients may undergo inadequate surgery by an obstetrician gynecologist without being referred, thinking that the patient is young. She may have a benign ovarian mass, but in fact is discovered to have a malignancy and therefore would require probably a second surgery in most instances. That's the sort of scenario we'd like to avoid. The surgical procedure itself, if the tumor is seemingly confined to the ovary or ovaries, then a hysterectomy and bilateral salpingo-furectomy, along with comprehensive surgical staging, is recommended. But if the patient hasn't completed childbearing, there may be an opportunity in selected patients for fertility-sparing surgery with retention of possibly the uterus and one ovary or the uterus and part of one ovary in these young patients. Also, increasingly, we are seeing young patients who are retaining fertility undergoing IVF with oocyte retrieval and cryopreservation for future pregnancies in this population. If the tumor is obviously metastatic in stage 2, 3, or 4, then maximal cytoreductive surgery to achieve no gross residual disease is the primary goal. Hysterectomy, bilateral salpingo-furectomy, omentectomy, and resection of all gross tumor. There have been a number of studies reported over the past few years, all of which tell us that if a patient with advanced stage low-grade serous ovarian cancer can undergo surgery with no gross residual disease at the completion of that surgery, those patients will have a significantly better outcome in terms of progression-free survival or overall survival. So very consistent results. However, there are important considerations following surgery for low-grade serous ovarian cancer. One might want to consider requesting a second opinion on the pathology because these are very rare tumors. We do observe some inexperienced pathologists misdiagnosing low-grade serous ovarian cancer, for instance, for high-grade serous ovarian cancer, or serous borderline tumor for low-grade serous ovarian cancer, or vice versa. So I think in many instances, it would be recommended to obtain a second opinion on the pathology. One might also, of course, want to seek a second opinion regarding post-operative management. We generally do recommend a post-operative baseline imaging study, usually a CT scan of the chest, abdomen, pelvis, to determine that baseline for future reference for the monitoring later on. Genetic testing is recommended as well as somatic tumor testing or genomic profiling to determine if the tumor contains any of the mutations I've mentioned previously. Regardless of the postoperative treatment, we do certainly recommend monitoring for all women with low-grade serous ovarian cancer, regardless of stage, and this would include periodic imaging studies as well as CA-125. I've mentioned that low-grade serous ovarian cancer is not as sensitive to cytotoxic chemotherapy as high-grade serous ovarian cancer. And up until about 2017, the standard treatment for women postoperatively with this disease was chemotherapy alone. And what we found from all of these studies is that the outcomes were not that terrific in terms of progression-free survival and overall survival, not nearly as good as they are today. And so in 2017, there were two retrospective studies that were reported. One from the MD Anderson group on the left, were 203 women who underwent primary cytoreductive surgery for low-grade serous ovarian cancer. 133 of these women underwent just chemotherapy alone following the surgery, but 70 women underwent chemotherapy followed by some type of hormonal maintenance therapy. And we found that that latter cohort had a much better progression-free survival than patients who just underwent surgery and chemotherapy without hormonal maintenance therapy. Likewise, the Johns Hopkins group reported a smaller cohort of patients, 27 women with stage 2 to 4 low-grade serous ovarian cancer, who underwent surgery followed by hormonal therapy, so no chemotherapy at all. And although they didn't have as mature results, their median progression-free survival, or at least their 3-year progression-free survival and overall survival, mimicked what we found in the study from the MD Anderson group. So based on these two retrospective studies, this randomized phase 3 trial was developed by NRG Oncology, in which women with stage 2, 3, or 4 low-grade serous ovarian cancer underwent primary cytoreductive surgery and then were randomized in a 1-to-1 ratio to either paclitaxel carboplatin chemotherapy for 6 cycles, followed by letrozole maintenance therapy, versus just letrozole monotherapy without prior chemotherapy. This trial just completed accrual in the last couple of months. 450 women were enrolled in the trial. And so right now we're awaiting the results that may come sometime, hopefully in the next year or two as the trial data matures. But this is a very important trial because if we do find that letrozole monotherapy is just as good as chemotherapy followed by letrozole, we'll be able to abandon chemotherapy altogether in the first-line treatment of this disease. This is the NCCN guideline for low-grade serous ovarian cancer, and at the bottom of this, you can see for stage 2, 3, and 4, the options are just the two I mentioned that are contained in that clinical trial. For stage 1A or 1B, the disease is confined to one or both ovaries, then observation is the postoperative management. For stage 1C, where patients have tumor on the external surface of the ovary, or they have ascites fluid with positive cytology, or they have rupture, we actually don't know how to manage these patients because, as you can see, the three options recommended for consideration by NCCN are either observation, chemotherapy followed by letrozole, or letrozole without prior chemotherapy. So we really are right now at odds about how to manage patients with stage 1C, but they comprise a minimum of number of patients. One of the things that has occurred to us recently is that we may want to consider adding Avastin or bevacizumab to frontline chemotherapy if, in fact, the clinical trial indicates we should continue to use chemotherapy for first line. There were two studies in the recurrent setting, one from Memorial Sloan Kettering, the other from MD Anderson, both of which showed a 40% or greater response rate to bevacizumab in the recurrent setting. And then more recently, a study was reported from Italy in which, and this was a retrospective report, in which they compared women who underwent surgery followed by chemotherapy alone to those who underwent surgery followed by chemotherapy plus bevacizumab. And they found that the outcome in the latter group was much better, a progression-free, median progression-free survival of 47.9 months versus 22.6 months. There is a role for what's called neoadjuvant chemotherapy in low-grade serous ovarian cancer. This is giving chemotherapy or some type of treatment prior to a major surgery. Well, when would we consider this? It's not the preferred approach, certainly, but however, there's a small proportion of women who may be candidates based on extremely extensive disease in the abdomen or comorbidities. This decision is a difficult decision, and it should be made by a gynecologic oncologist. There are no absolute criteria for choosing between primary surgery and neoadjuvant treatment. The two modalities that we have are either imaging with usually CT scanning or a laparoscopic assessment to assess the tumor bulk and determine if a major debulking surgery should be performed. Neoadjuvant treatment usually, at least at the present time, consists of 3 to 6 cycles of chemotherapy, followed by the interval cytoreductive surgery, and then further systemic therapy. Unfortunately, there are two studies recently reported in the literature that have documented that there's been somewhat of an increase in the use of neoadjuvant chemotherapy for low-grade serous ovarian cancer in the United States. And that's actually a trend that we would like to see go away because, as I mentioned, neoadjuvant chemotherapy or neoadjuvant treatment of some type is really not the preferred approach. This slide shows you two studies, one from MD Anderson by Dr. Cobb, in which 36 women with advanced stage low-grade serous ovarian cancer were compared to 36 women with high-grade serous ovarian cancer. All of these patients received neoadjuvant chemotherapy prior to interval debulking surgery. The response rate in the low-grade serous ovarian cancer population was 11% versus 75% in the high-grade serous population, so less sensitive to chemotherapy. And then the Memorial Sloan Kettering study showed a similar low response rate of 9% in women with low-grade serous ovarian cancer treated with neoadjuvant chemotherapy. Based on this these disappointing findings, a few years ago, the MD Anderson group designed this study, completely getting away from chemotherapy and using neoadjuvant endocrine therapy with a drug called fulvestrant, combined with the CDK4/6 inhibitor abemaciclib. We know from many breast cancer studies over the past few years that when you combine an endocrine drug with a CDK4/6 inhibitor, the activity is much higher. It's a much more effective regimen. And so this was used in 15 women who presented with unresectable, extensive low-grade serous ovarian cancer. And then some of these women went on to have surgery after the treatment. And on the left, you can see the data I showed you in a previous slide, where only 11% of women who received neoadjuvant chemotherapy for low-grade serous ovarian cancer responded. And in this study with abemaciclib and fulvestrant, the response rate was a remarkable 60%. And so this looks like a very active regimen for treatment, a neoadjuvant treatment of low-grade serous ovarian cancer. There's another study that's actually still recruiting from Memorial Sloan Kettering and other sites for patients with unresectable low-grade serous ovarian cancer, also for patients who actually undergo primary surgery but are not able to get to no gross residual disease. These patients are treated with the combination of a MEK inhibitor, avutometinib, combined with a FAK inhibitor. Rachel's going to talk about that more in the treatment of recurrent disease in a few minutes, and that's combined with letrozole. And so again, this is another strategy aimed at trying to improve greatly over what we have found in the last few years with neoadjuvant chemotherapy. So these are the available frontline trials that have either been completed or are ongoing. The first two are the two neoadjuvant trials I just mentioned with the fulvestrant abemaciclib or the avutometinib defactinib letrozole. The third one there is that frontline adjuvant treatment trial of carboplatin paclitaxel followed by letrozole versus letrozole monotherapy, where the accruals also been completed. And then there are two European studies. One that's is comparing carboplatin paclitaxel chemotherapy with letrozole alone in the adjuvant setting. And then there's a maintenance therapy European study comparing letrozole to placebo. A few years ago, the family of a young woman with low-grade serous ovarian cancer from New Zealand, Jane Ludeman, committed substantial funding for the study of low-grade serous ovarian cancer. And this caused us to organize an international group of physicians, scientists, and patient advocates. So there are about 30 individuals currently involved in this international consortium. And we're looking at this strategy for making accelerated progress over the next few years through preclinical laboratory-based studies, clinical trials, as well as a rare tumor registry for women with low-grade serous ovarian cancer. So in conclusion, I'd like to thank the patients with low-grade serous ovarian cancer we care for and their families. I particularly like to thank the Ovarian Cancer Research Alliance, as well as the International Consortium for Low-Grade Serous Ovarian Cancer. Thank you very much. And now I will turn it over to Rachel to discuss the treatment options for recurrent low-grade serous ovarian cancer.
Thank you so much, Dr. Gershenson. It's always a pleasure to get to present alongside Dr. Gershenson, my friend and colleague who's done so much to further our understanding of low-grade serous ovarian cancer as a disease and help to develop the treatments that we now have available for our patients with low-grade serous ovarian cancer. And also thank you to the OCRA for this invitation to speak today. I'm very excited to talk to you about some new options that we have for treatment of recurrent low-grade serous ovarian cancer. My name is Rachel Grisham. I'm a gynecologic medical oncologist at Memorial Sloan Kettering Cancer Center in New York, where I'm the section head of ovarian cancer and also the director of gynecologic medical oncology at MSK Westchester. These are my disclosures. So as Dr. Gershenson mentioned, the most targetable pathway in patients with low-grade serous ovarian cancer is the MAP kinase pathway. This is a pathway that, when activated, leads to ability for cells to continue to replicate and thereby become larger cancerous cells that can migrate and overcome the restrictions that usually keep our normal cells from staying in one place. About a third of patients with low-grade serous ovarian cancer will have a KRAS mutation in their tumors, and then other alterations in this pathway can also be affected in patients with low-grade serous ovarian cancer, such as V600E BRAF mutations, NF1 mutations, NRAS mutations, and others, including fusions. As Dr. Gershenson mentioned, our patients who are younger, unfortunately, are less likely to have a targetable KRAS mutation and more likely do have aggressive disease, while our patients who are older at the time of diagnosis are a bit more likely to have these KRAS mutations and also tend to have more of that stereotypical indolent disease that can be slower growing and more responsive to endocrine therapy. However, luckily, recent clinical trials are working on ways both to target the MAP kinase pathway, but also to develop treatments for our patients who do not harbor readily identifiable mutations within this pathway. So the first MEK inhibitor, the first targeted therapy targeting the MAP kinase pathway that was evaluated in a clinical trial specifically for patients with low-grade serous ovarian cancer was selumetinib, which was looked at in the GOG 239 study. So this study enrolled women with recurrent low-grade serous ovarian cancer who had measurable disease and had received prior therapy. Patients were treated with this oral targeted drug, selumetinib, which is a single-agent MEK inhibitor, and remained on treatment for as long as that treatment was working. Now, based on those historically low response rates to chemotherapy and endocrine therapy, the response rate of 15% in this study was found to be promising. Now, back when the study was published in 2012, at that time, our ability to do large-scale sequencing was more limited. So for those patients that had available archival tissue, sequenome analysis, which is analysis of single hotspot mutations on genes, did not show an association between KRAS or BRAF mutation and response to therapy. However, since that time, our ability to do deep, in-depth sequencing on patients' tumors routinely has drastically improved, making it now possible for us to better understand which patients are most sensitive to treatment with targeted therapy. However, we did learn quite a bit from this early study, including that some patients can be long-term responders to single-agent MEK inhibitor. These are two different case reports that were published based on patients treated on that selumetinib study. One of them was a patient treated at MD Anderson who initiated treatment for recurrent low-grade serous ovarian cancer with selumetinib in June of 2008 and had an ongoing response for more than 10 years. And it was noted at times that when the patient held drug, her cancer would start to grow back, but then again rescinded once they became smaller once the patients resumed the drug. Another patient treated at Memorial Sloan Kettering Cancer Center initiated treatment on this study in October of 2009 after having received multiple prior lines of chemotherapy and endocrine therapy for her recurrent low-grade serous ovarian cancer. At the time that she went on to study, she actually obtained a complete response with no visible cancer. And that has been a sustained complete response to this day, now more than 15 years since she first initiated on treatment with that drug under study. At the time of the study, she was not found to have any identifiable alterations. However, we subsequently were able to do deep next-generation sequencing on her archival tumor tissue and found that she had a 15 base pair in-frame deletion within the MAP2K1 gene, indicating that patients with alterations other than the commonly identified KRAS, BRAF, NF1 alterations that we commonly described for this disease can also have sustained responses to treatment with targeted MEK inhibition. After this study came two very important studies looking at single-agent MEK inhibitors for patients with recurrent low-grade serous ovarian cancer. The GOG 281 study that was led by Dr. Gershenson looked at patients with recurrent low-grade serous ovarian cancer and treated them either with a single-agent MEK inhibitor called trametinib or a physician's choice of chemotherapy or endocrine therapy. That study was a positive study and showed that those patients treated with trametinib had a 26% response rate versus only 6% of patients treated with standard of care physician's choice therapy having a response. Another study looking at a single-agent MEK inhibitor was the MILO study. This one used a different MEK inhibitor, binimetinib, versus physician's choice of chemotherapy. Here, different radiology assessments were used, and overall the response rate was 16% to that MEK inhibitor, and still higher than that seen with the physician's choice of chemotherapy at 13%. Following these studies, both trametinib and binimetinib became NCCN compendium listed as options for patients with recurrent low-grade serous ovarian cancer, giving us now a targeted treatment option that can be given by prescription to our patients. As Dr. Gershenson noted, those patients who have a KRAS mutation and other MAP kinase alterations have also been associated with improved prognosis. And these patients can have improved responses both to standard of care therapy and to treatment with MEK inhibitors. In the MILO study and in the trametinib study, those patients with a MAP kinase alteration had the best responses. Now, these responses of single-agent MEK inhibitors have been quite promising. However, we want more than 25% of our patients to respond to a targeted therapy. And so, of course, the next generation of studies are trying to find how can we get even deeper responses for our patients? And also, when possible, how can we decrease toxicity? Because if our patients are going to be on these treatments for a prolonged period of time, we certainly want them to be manageable and for patients to be able to live their normal lives. This leads us to the recently completed clinical trials of avutometinib and defactinib. So avutometinib is a first-in-class oral RAF/MEK clamp, and defactinib is a FAK inhibitor. These are both oral targeted therapies that work through multiple mechanisms to both inhibit the MAP kinase pathway and also help try to prevent compensatory reactivation of that pathway. A phase 1 study called the FRAME study looked at multiple different cancer types, including low-grade serous ovarian cancer, and found a very promising response rate of 42% using this drug combination in patients with recurrent low-grade serous ovarian cancer, and with very sustained responses. That phase 1 study led to FDA breakthrough therapy designation for this combination and the subsequent development of a phase 2 study called the RAMP 201 study, which specifically looked at the use of these targeted drugs for women with recurrent low-grade serous ovarian cancer. So the RAMP 201 study initially enrolled women with recurrent low-grade serous ovarian cancer who had received at least one prior line of chemotherapy and had measurable disease. Patients could have a KRAS mutation or not have a KRAS mutation. We just needed to know what their mutation status was before they started on the study. Initially, patients were randomized to either receive a high dose of avutometinib by itself or the combination of avutometinib and defactinib at the standard dosing. Following the initial randomization, it was determined that the combination of avutometinib and defactinib was more active and had similar toxicity to the single-agent avutometinib at a higher dose. Therefore, the combination of avutometinib and defactinib was chosen to be the go-forward regimen, and subsequent patients enrolled to that study received the combination. At the end of the study, there was also a dose optimization cohort where patients received a lower dose of avutometinib in combination with defactinib to see if a lower dose could potentially be just as efficacious with less toxicity. The primary endpoint of this study was response rate, so percentage of patients who had at least a 30% decrease in tumor volume while on study. These patients had received multiple prior therapies, a median of 3 prior lines of therapy before going on study. About half the patients had received prior bevacizumab, and about a quarter of the patients had actually received a prior single-agent MEK inhibitor like trametinib or binimetinib before going on study. And we see here these really impressive results for the combination. Overall, 82% of patients who enrolled onto the RAMP 201 study and were treated with the combination had a reduction in their target lesions. The confirmed overall response rate for the overall trial population was 31%, with the highest response rate seen in those patients who had a KRAS mutation. So for those patients with a KRAS mutation, the response rate was 44%. And for those patients who did not have a KRAS mutation, the response rate was 17%. Now, 17% is certainly lower than 44%, but still a promising result for these patients who often have an overall worse prognosis and lower response rates to any treatment, whether it be chemotherapy, targeted therapy, or this combination therapy. These responses were generally also durable. The median progression-free survival was 12.9 months, and specifically in those patients with a KRAS mutation, 22 months, meaning that at 22 months, half the patients remained on treatment. And the duration of response is something that I think is truly remarkable here. The median duration of response was 31.1 months. So once these patients responded to the treatment, it was sustained and lasted for a prolonged period of time, in this case for years, which is so important because we don't just want to have a response that's short-lived, we want that response to endure. A subgroup analysis showed that those patients who received the combination earlier, so before having more prior lines of therapy, did have the highest response rates, as one might expect. These very promising results led to this combination of avutometinib and defactinib receiving accelerated FDA approval specifically for those patients with recurrent low-grade serous ovarian cancer who have a KRAS mutation. This approval just came through on May 8th of 2025 and marks the first drug combination, and also the first drug at all, ever specifically FDA approved for patients with low-grade serous ovarian cancer. Now, while this is currently approved only for those patients who have a KRAS mutation, there is a confirmatory phase 3 study going on right now. This study has completed accrual for now in the United States, though there is a chance it may reopen to enrollment in the future, but has accrued very well. And is randomizing patients with recurrent disease to the combination of avutometinib and defactinib versus physician's choice of therapy. Now, similar to the RAMP 201 study, this study allows patients with or without a KRAS mutation. You just need to know ahead of time whether the patients have a KRAS mutation. Now, once we are able to compare this combination of avutometinib and defactinib to standard of care therapy, chemotherapy or endocrine therapy, it may be found that the combination is better than standard of care therapy, both for patients with and without a KRAS mutation. We don't know. That's what the study is meant to determine. But this study could hopefully lead to the approval of these drugs for all patients if positive. The primary endpoint of the study is progression-free survival, and then we'll of course look at other factors like response rate, overall survival, and progression-free survival, both for those patients with and without a KRAS mutation. So we eagerly await the results of the RAMP 301 study, the confirmatory phase 3 study, and are so grateful to all of our patients who participated both in the RAMP 201 and the RAMP 301 and that phase 1 FRAME study to allow for this drug combination to now be FDA approved and available for our patients with recurrent low-grade serous ovarian cancer. Now, these drugs do, of course, have side effects. So the main side effects that we're seeing with avutometinib and defactinib include GI side effects like nausea, diarrhea, peripheral edema, which can be seen in the hands or feet, and then acneiform rash. Now, this rash is very common with MEK inhibitors. Luckily, on these studies, the avutometinib is given just twice a week, 3 weeks on, 1 week off, in combination with the defactinib, twice a day, 3 weeks on, 1 week off. And that intermittent dosing seems to help mitigate some of the toxicities that we commonly see with MEK inhibitors. In the RAMP 201 study, only 10% of patients discontinued treatment due to side effects, which is lower than the rates of study discontinuation that we saw in prior studies of single-agent MEK inhibitors for low-grade serous ovarian cancer. Now, some specific toxicities that we worry about that can come on quite early are primarily visual side effects and the skin side effect. So patients can experience blurred vision when treated with this combination, and therefore it's very important that all patients have a baseline optho-eval before they go on treatment. When these visual side effects do occur, it's usually during the first week that when patients first start treatment. And interestingly, most cases of blurred vision or visual side effects go away spontaneously without any need for holding drug. But in order to make that decision, of course, a patient must be seen by a qualified ophthalmologist to make sure it's safe to continue on study. But important to know this information because we don't want patients coming off prematurely if their visual side effects were going to quickly go away. And then the skin toxicity, which is an acneiform rash on the face and upper chest area most commonly. The best way to help prevent that is to take a prophylactic antibiotic, such as minocycline or doxycycline, at the time of study initiation. And what we've learned is it's so important to use that prophylaxis. If we wait until the rash develops, it's much harder to treat than if we use these measures before we start treatment to help prevent the rash. This rash is also generally brought on by sun exposure, and so it's important to use sun protection such as hats and long sleeve shirts and try to avoid prolonged sun exposure when on treatment with these drugs. The package insert for these drugs also gives information about how to try to monitor for toxicity and the best way to try to avoid toxicities from this combination. Now, I mentioned that these drugs are now FDA approved specifically for patients with a KRAS mutation. It's now the standard of care that all patients with ovarian cancer should routinely have both germline and somatic tumor testing performed in order to see if they have a hereditary cause for their ovarian cancer and also to see what somatic mutations they may have, including KRAS mutation. Now, there's different ways of doing this somatic testing, meaning looking for the mutation specifically in the tumor and not in every cell of the body. And one way is to look specifically at the tumor tissue. So after surgery, we usually keep that tumor tissue in storage in FFPE blocks, formalin-fixed paraffin-embedded blocks that are kept in storage, usually for many, many years after someone's surgery. Or the other way is to do a liquid biopsy, so looking at circulating tumor DNA. So circulating tumor DNA is something that has become a common practice across many cancer types over the past few years and is commonly used for different types of cancer, including lung cancer and colon cancer, in order to determine if targetable alterations are present. As part of the RAMP 201 study, it was looked at circulating tumor DNA to see if this was a reliable way to identify if patients had a KRAS mutation. Now, what this analysis found was that it was not very reliable. The concordance rate between the identification of KRAS mutations in the circulating tumor DNA and the KRAS mutations in the tumor tissue was not good, only about 44%. And this is due to several factors, including that low-grade serous ovarian cancer can be a low shedder. And so you can have false negatives where you do not identify the KRAS mutation, even though it is present in the tumor tissue. So I recommend to my patients, especially with low-grade serous ovarian cancer, that their tumor somatic testing be done on the tumor tissue itself and not as a liquid biopsy, not done on their blood. And so I think that's an important thing to think about when we're having that testing done. And as Dr. Gershenson mentioned, we need to be looking at better options for our patients that are not amenable to primary surgery when they're first diagnosed with low-grade serous ovarian cancer. We have studies right now looking at chemotherapy versus endocrine therapy, but seeing these promising results in the recurrent setting, it's very compelling to try to see, can these drugs also improve outcomes for our patients when they're first diagnosed and not have to wait until they develop recurrent disease. And so the Chameleon study, which Dr. Gershenson mentioned, is looking at this combination of avutometinib and defactinib in combination with letrozole for our patients who have advanced disease that's not amenable to primary surgical debulking, or who after their initial surgery have had a suboptimal debulking and still have residual disease left behind. And this study aims to see if these patients can have a good response with this combination. This study was first developed by Dr. Beryl Manning-Geist when she was at Sloan Kettering through the SGO Bridges program with mentorship from Dr. Gershenson and myself. So very proud of her in developing this innovative study. Now, of course, we want to look for other options for our treatment also. It's great to have this drug combination approved now, and we're looking at it in different settings, but we need other options as well for our patients, both who have targetable alterations and those who do not. And so Dr. Gershenson mentioned the use of CDK4/6 inhibitors, which have shown promising results in a neoadjuvant pilot, and also in the setting of recurrent disease. And so GOG 3026 looked at the combination of letrozole with ribociclib, both oral therapies, in women with recurrent low-grade serous ovarian cancer. And this study, at the time of last presentation, showed a response rate of 23%, so quite promising. So as both this study and the neoadjuvant study presented previously by Dr. Cobb and Dr. Gershenson become published and give us more information, hopefully these drug combinations will become an option for our patients in the near future. And something that's been a big area of development across all cancer types is antibody drug conjugates, ADCs. And so these are drugs where an antibody binds to a specific protein on a cancer cell, has a linker that then dissolves or breaks, releasing a warhead, a cytotoxic compound, either into the cancer cell or in the area immediately surrounding the cancer cell to try to provide large concentrations of cytotoxic therapies specifically to the cancer cells expressing that protein. So we now have two ADCs that are that can be used in ovarian cancer, one specifically approved for ovarian cancer, the other with a histology agnostic indication. And so mirvetuximab specifically targets folate receptor alpha, which is a protein that can be found on ovarian cancer cells. And trastuzumab deruxtecan specifically targets HER2, which is another protein that can be found on cancer cells. Now, the level of HER2 expression in low-grade serous ovarian cancer right now is generally considered to be low, but I would say we have to learn more about how it can change over time. And so I do have multiple patients with low-grade serous ovarian cancer who were initially HER2 negative, and then upon repeat biopsy later became HER2 positive. And so we're doing studies right now to try to better describe the natural history of how HER2 expression can change over time. But unlike mutations like KRAS, which generally stay the same, either you have one or you don't, HER2 and folate receptor alpha and other protein expressions on cancer cells can change over time. And so oftentimes we test tumors for these multiple times over a patient's life to see how the expression levels are changing. So folate receptor alpha does have a high level of expression in low-grade serous ovarian cancer. So in a study that we looked at Memorial Sloan Kettering Cancer Center, we found that about 40% of our patients with low-grade serous ovarian cancer were high expressors of folate receptor alpha. And those patients are currently candidates for treatment with mirvetuximab. And also those patients with a lower level of expression, moderate expressors, also have a compendium listing where they can be treated with the combination of mirvetuximab with bevacizumab. So as we continue to treat our patients with these new ADCs, we will obtain more information about the relative response rate of those drugs, specifically in patients with low-grade serous ovarian cancer. We also found that the rate of folate receptor alpha expression was inversely correlated with whether patients had a MAP kinase alteration, which is interesting and may help us to prioritize the ordering of which drugs patients receive. And so now we have multiple different targets and options for our patients with recurrent low-grade serous ovarian cancer. And so it's important that if somebody has low-grade serous ovarian cancer, that they know if they have any of these targets. So you need somatic tumor testing to know if you have a KRAS mutation or a BRAF mutation, as there are approved drugs that specifically target those mutations. You also need to know if your tumor had IHC, immunohistochemistry testing, in order to see if it expresses HER2 or folate receptor alpha, because there are targeted drugs for cells that overexpress these proteins. And then also for patients who do not have any of these targets, these promising drug combinations of CDK4/6 inhibitors in combination with fulvestrant or letrozole are also likely to soon be an option for our patients. And so it's so exciting to see more options becoming available for our patients as we continue to try to develop new clinical trials and more options to try to improve our patients' outcomes and have them live longer and live better. So thank you to OCRA for all that you do to help support our patients and their families. And we're always so appreciative of everything that you do for our community. Thank you.